आता काय सर आलंय आता काय थोडा ऐकून थोडे पैसे शक्यतो नाही सोडवत या सर प्लीज त्याशिवाय चालतच नाही. तुम्ही तरुणांना आम्ही तरुण
Hello boss, so many occasions and episodes. 3 months.
Make you the host so that you can directly display if it is not working, then use this. Or else I will make you the host. So second will be yours. So you can give it a try.
माझा फॉर्म लेट झाला आज दिवसभर मी वरती गेलोच नाही रे शेअर खालीच होतो त्यामुळे हा कर ना माझा फॉर्म
Yes, working.
Very specific. धरून आपण कार्यक्रम करत असतो. हा येत आहे सर. संदीप झाले की ते सर तुम्ही चांगलं केलं सध्या शबाना हे आता हे असते सगळीकडे उद्या तुझं आज एक पण व्हिडिओ आणि आला नाही, उद्या पण कळतो.
हा ते परवाच चांगलंच गेलो तुम्ही रिमाइंडर वाचलं म्हणून ते रिमाइंडर प्रेझेंटेशन पण केलं
हां.
नव्हतं.
किती वाजले?
9-12.
टाईमच्या पुढे चाललोय आपण.
डे टू डे
स्टुडंट्स
विकास किधर है? फोन कर.
जस्ट रिंग देना. काय म्हणतात स्टार्ट झाले की मग
This thing has to be shared. This because we managed to do presenting first. So kindly make this.
येस सर. और क्या अमित भाई आज एकदम अटलास असं वाटतं मला.
ती सीईटी होती का तिची त्याला गेलो
तुझं सेंटर भेटायला कसली सीट? अच्छा. शी इज नॉट इंटरेस्टेड. त्यांना इंजिनिअरिंगला अजून मेडिकलमध्ये इंटरेस्ट नाही आहे.
एक नीट देणं किती सोयीस्कर गोष्ट आहे. ॲडव्हान्सची पार्ट 1 ॲडव्हान्सची पार्ट 2
पण त्यांनी काय दिलं
VIT झाली IIT झाली
त्याच्यामध्ये
आता ही CET झाली आता बिटसॅट आहे त्यानंतर ॲडव्हान्स्ड आहे आणि झिट आली आहे मला ऑलमोस्ट प्रत्येक शनिवार रविवार पुण्याला गेलो आणि आता ते ह्यांची आता VITची ॲडमिशन शनिवारी सुरू होणार हे बाकीचे जे रिझल्ट आहेत पण ह्यांची ॲडमिशन सुरू होणार मग त्याच्यानंतर पुढच्याची ॲडमिशन दुःख फिरायची जायची.
Once they go to engineering, we forget them. They will go to America.
पण जाईपर्यंत ते आपल्याला बघायला
नाही, एकदा ती गेली की मग ग्रॅज्युएशन झालं की प्लेसमेंट झाली की संपलं. MS च्या निमित्तानं जातात.
आज फक्त तुझा एकट्याचा फोन आलाय मला बाकी सगळे मिस कॉल
बघितलं
सगळे मिस कॉल फक्त तुझा एकट्याचा फोन आलाय.
लाईट गेली नाही ना.
नाही असते काय
मीच लोक काय
तरी ऑनलाईन नाही ती माणसं आमची घरी बसून
होय काय? अच्छा अच्छा. म्हणजे तुम्ही इथं पण ऑनलाईन नाही द्यायला पाहिजे ऍक्सेस मला तर वाटते लोकल मिरर्समध्ये डिस्ट्रिक्टमध्ये बरोबर पण लोकल यू शुड प्रमोट की दे शुड कम फिजिकली. नाही लोकल कसं आहे येतात अजून एक 15-20 मिनिटांनी एंटर हॉल गेट थोडंसं प्रॅक्टिस करायला लेट असते. ओपीडी असते नंतर पाऊस आहे पावसामध्ये का नाही आले आज लोक लेट. सांगलीला तुम्ही कपूरमध्ये घेतलाय का? बरं. हा ते महानगर रोडला
स्काय
आहे. ओके ओके तिथं सगळे सध्या तिथंच पळायला लागले.
पूर्वी ककून नव्हतं त्या ककूनची आमचीच टीम तिकडे गेली.
Oh my God.
त्या टीम बरोबर सगळी त्या टीम
तुमचे clients पण गेले तिकडं. I see. Oh my God. काय चांगलं आहे का ते?
दुर्गामाता देवळी
हा तू जातोस ना पुढं माधवनगर रोडला. ते दुर्गामाता.
बजाज होतं ना
हो, हो.
बजाजच्या समोर
बजाजच्या बरोबर सांग.
रत्ना हॉटेलच्या समोर
ते कोणी काढले?
हो पण बिल्डर
बिल्डर लोकांना
हा हे बघा खूप दिवसातनं.
हो सर ती पण 2 वीक नाही आहे त्यामुळं
आमचेच लोक पावसात अडकले लाईट पण नाहीये. हे बघा आले बॉस
आलेले आहे.
बॉस आमच्या समोर घेऊन आलो त्यांना खाली.
असं झालंय होय?
ते भाई श्रीनिवास सर थांबलेले बोलत
हो सर हे लय मारतात मला. ओके ओके नो प्रॉब्लेम लाईट्स नव्हत्या 5 मजले चढायचे म्हणजे मला फोन पण विचार तुझ्या फोनवर जरा करून बोलवून नाही स्लॅकिस्ट पिरियड आहे काय पेशंट हा प्रॉब्लेम आहे पाऊस पडला
आपण गावाला घेतो
फ्रेश
मध्ये या काळात आम्ही गावाला गेलो.
हे बाळा सुरू करूया ऑनलाईन आहे तसं गॅस कमी ओके त्याच्यावर माफ 10 वाजेपर्यंत उभं राहायला लागतं असं
स्टार्ट करूया.
सुरू करूया संदीप
A very good evening and a hearty welcome to all.
तुझं बोलणं सुरू
At the outset, let us go through the activities performed in the month of May, that is the month of
ऑनलाईन असल्यामुळं सगळे युट्यूबवर असल्यामुळं यू विल बी देअर एव्हरीवेअर. अरे नाही बाळा तू बस
Thalassemia event was held in
Mike.
on the 8th of May,
नो प्रॉब्लेम.
under which free hemoglobin checkup was conducted, along with the drawing competition with prize distribution for women refreshments. A special felicitation of Dr. Srinivas sir was done for his service towards the thalassemia
So
patients.
make untext.
तिला
On
थांबा
9th
ना
of
2
May,
मिनिट.
an event
Okay.
was
अरे
held
ये
in
की कुठं आहे?
GMC Meerut, which included a free hemoglobin checkup, drawing competition with prize distribution followed by refreshments. A special felicitation of Dr. Amnapure sir was done for establishment. A very good evening and a hearty welcome to all. At the onset, let us first go through the activities performed in the month of May, that is the month of Thalassemia by IAP Sangli district branch. Thalassemia event was held in Bharti Hospital on the 8th of May, under which free hemoglobin checkup was conducted, along with a drawing competition with prize distribution followed by refreshments. A special felicitation of Dr. Srinivas sir was done for his service towards thalassemia patients. On 9th of May, an event was held in GMC Meerut, which included a free hemoglobin checkup, drawing competition with prize distribution and refreshments, and a special felicitation of Dr. Amnapure sir for establishing a thalassemia daycare center at his unit. The thalassemia awareness video by our senior pediatricians was played at both these events. Third, the thalassemia awareness was conducted on a large scale among the local public through radio on Green FM 90.4. And lastly, the IAP meeting held tonight, wherein our topic of discussion will be what is new in thalassemia. Now, thalassemia can have a number of physical and psychological repercussions on a child's quality of life. Today, advancement in transfusion and ion chelation therapy has no doubt extended the life expectancy of thalassemia patients, but their quality of life remains poor compared to their healthy counterparts. Hence, we need to focus on the novel approaches in the management of thalassemia. To enlighten us on the newer approaches in thalassemia, we have experts in this field with us today, namely Dr. Sudeep Nemani sir, Dr. Abhilasha S. Madam, and Dr. Preeti Naik Madam. I now call on stage Dr. Srinivas sir, our chairperson, who is a senior pediatrician of Meerut and has been treating thalassemia patients for the last 45 years. Dr. Srinivas sir will now introduce and call Dr. Nemani sir on stage.
Good evening, everybody. At the outset, I thank Dr. Madhin sir and all the office bearers and IAP members for having asked me to chair this important session. I've been given the task of introducing Dr. Sandeep Nemani. He is an MBBS from GNC around Meerut. He stood first in college in almost all the academic years. He has secured distinction in majority subjects. He got gold medal in subject of P&SM. He did his MD in internal medicine in Nair Hospital, Mumbai, and he stood first in college in MBA examination. He was interested in hematology right from his MBBS career. He did his DM from the prestigious Institute of Christian Medical College, Vellore. There also he stood first for the MGR University, Tamil Nadu, and secured a gold medal. He has worked as an assistant professor in Department of Hematology there. During his tenure of 4 years, he has been part of various publications, both national and international, especially European Hematology Association. His latest publication is on stem cell transplant in acute myeloid leukemia. It is also published in Journal of Global Oncology. Right now, he is working as a consultant hematologist and stem cell transplant physician at Cancer Hospital, Meerut. And of course, he also has his private setup in Usha Hematology Center. And he has done so far 30 successful
to transplant. So even the outcomes look similar in the Western data. You have to consider this point before we not to offer transplant to any child with thalassemia major. So coming to this principles of allogeneic stem. So here what we do is we give some chemotherapies to ablate the bone marrow. So we have to kill the patient's own cells so that we create a space for the patient donor cells. So this is called as conditioning regimen, where we ablate the bone marrow of the patient, and then we take the stem cells from the patient, from the donor, and we infuse the conditioning has been done, and then the patient's donor stem cells are taken and they are infused into the recipient after conditioning. So the space is created in the bone marrow to accept the donor cells, and then the recipient after some time, after 2 to 3 weeks, recovers and his hematopoiesis of the donor establishes inside his bone marrow. But it is not that easy, as we say, and a lot of problems come with that. There is something called as engraftment syndrome that can happen with the donor cells. There is chances of rejection. The donor cells get rejected and the patient can become again aplastic or can become thalassemic again. GVHD, that means the donor cells which have the T cells which are immune reactive to the patient, and they cause reaction inside the body of the patient, causing skin disease, liver disease, diarrhea, bloody diarrhea, and sometimes it can be fatal and patient can die of graft versus host disease. Then regimen related toxicity. That means the conditioning regimen that we have used, the chemotherapeutic drugs that we have used in conditioning, that can cause SOS, that means sinusoidal obstruction syndrome. The older term is veno-occlusive disease of liver. So that can again be fatal in case of thalassemia individuals. Infections. After transplant, the immunoreconstitution takes months to years. So in that period, they have different infections that are common after doing transplants.
and that again can become fatal. Some fungal infections, viral infections, CMV, everything can be fatal in case of post-transplant patients. There are other complications as well. There can be chronic GVHD, there can be feeding issues, a lot of things can happen, and the quality of life can be problematic even if we do transplant, if the patient lands up in trouble. So this also needs to be considered, and when we explain to the patient, transplant is not the magic, but it can cure if there is a match donor available. It can cure up to 80 to 90% of the individuals, but 20% patient can land up in long-term complications, or even they can succumb to their post-transplant complications. That family needs to understand. So as I told you, the conditioning regimen can be myeloablative. That means it can ablate the bone marrow completely, or it can be reduced intensity conditioning or non-myeloablative, where only some space is created, immunosuppression is created, and the cells are infused. The stem cell source from the donor can be either a bone marrow. So we can take a bone marrow source sample as stem cells. We can take a peripheral blood stem cell on the apheresis machine, the machine that is used for platelet apheresis. Same machine, we can do a stem cell apheresis as well from the donor, and that can be infused into the patient. That's the commonest transplant that we do, the peripheral blood stem cell transplant. And third is the cord blood transplant, that all we know, but it's going little out of fashion of doing cord blood that we can discuss later on. Donor, what could be the donor? Donor could be a match related donor. So sibling who is full match, full HLA 10 by 10 match can be a donor. Mismatch related, so one antigen mismatch, two antigen mismatch, but a sibling or a family member. Match unrelated, that means there are some registries, like there is, we call it Gatri registry in India, or there are DKMS registry from the Germany, or NMDP registry from US, so where they have database of all the HLAs, and if you find a match donor outside family, you can take their stem cells and do the transplant with this individual. So this is match unrelated, no relation with the blood, but it is matched in HLA. Mismatch unrelated, so one antigen or two antigen mismatch donor can be taken for transplant with little high risk if he is not family member. And last is the haploidentical transplant, where nowadays even with 50% match. So always remember, our parents are 50% match with us. Our children are 50% match with us. With haploidentical transplant, everybody has a donor. So full match sibling, chances are around 25% to get a full match sibling donor. But when we say haploidentical, our parents are haplomatched to us, our children are haplomatched to us. So every individual will get a donor if haplomatch transplant to be done. So as I told you, HLA we know, it's on short arm of chromosome 6. There are some antigens which are represented on the surface of the cells and which are important to be matched because to avoid both rejection as well as graft versus host disease. So we know it has autosomal co-dominant expression, Mendelian expression is there. This is mother and father. A, B is the mother haplotypes, and C and D are the fathers. And we get different permutation and combination in the children. So 4 possibilities are there in children to get in HLAs that we can see. And a particular individual of AD will have 25% chance that he will have an identical sibling, full match. He will have 50% chance that one of his sibling will be half match, and 25% chance that it will be totally mismatched. So you can see this AD is totally mismatched with CB, but this AD has 25%. So 1 in 4 probability, 1 in 4 chance of getting a full match in siblings. So as the number of siblings increases, the chances that you will get a full match donor also increases. The probability of getting a full match donor increases. So if you have 10 siblings, you have a chance of 95% that you will have a match sibling in your family. But if only you have 1 sibling, the chance is 25%. So it's a chance, like we throw a dice, you get a chance of getting 6 is 1 in 6 because it has 6 spaces. Like that, 25% chance means 1 in 4. So if you have 4 children, there is one of them can be matched, but that is not absolute, and it cannot go to 100%. Even if you have 100 siblings, still it will not be 100% that you will have a match. Cost of transplant, match sibling donor approximately for thalassemia 12 to 14 lakhs in our country. Match unrelated donor goes up to 40 lakhs because the donor, procuring of stem cell from outer countries and this all logistics and getting the stem cell becomes difficult. Haploidentical transplant goes up to 25 lakh rupees, and cord blood again it matches the cost of the match unrelated donor transplant. Other important cost drivers we have to understand in transplant is the graft rejection. The cost increases because the patient has rejected the graft. Repeat transplant may be required in that individual, or the patient may require supportive care for long duration because we have converted a thalassemia to an aplastic anemia. Then GVHD, if GVHD can prolong for months, patient can get admitted for even months to years for GVHD. So that cost increases. And infections, again CMV treatments, a lot of new drugs are there like pseudofovir which are very costly in managing transplant patients post-transplant. So we see a lot of endorsement happening for cord blood. It has reduced now, I believe, but still we should know that the cord blood preservation in thalassemia per se, we say it's of no use, because the cord blood which you have preserved and trying to do a transplant for that individual, the same genes will be there in the cord blood stem cells as well. You have to do an allogenic cord blood transplant. So there should be a public cord blood bank where you have taken a cord blood from another individual and done a transplant for this thalassemia child. But for this particular child, his own cord blood for a private cord blood banking will not be of use. When cord blood will be useful is one child is already thalassemia major, the second child is normal, his cord can be used for the previous child. But that too again, the previous child should be less than 30 kg of weight, less than 12 years of age. This all criteria should satisfy, and the cord blood takes long time to recover from the transplant because it takes months for engraftment. So cord blood transplant is difficult. We usually don't do. I had never seen or done any cord blood transplant in my even in DM curriculum as well. So allogenic stem cell transplant remains the only curative option as of now. Gene therapy is coming up for beta thalassemia major. The correction of this disorder by allogenic stem cell transplant was described first by the Donald Thomas, and here he is getting the Nobel Prize for transplant success. Subsequently, conditioning regimen of busulfan and cyclophosphamide, the chemotherapeutic drugs that are used initially, where busulfan and cyclophosphamide was the established for stem cell transplantation in this condition. This myeloablative, which is killing bone marrow totally of the individual, forms the basis of currently conditioning regimens of this condition. So what is the risk stratification? This we all should know about how we risk stratify the thalassemia individuals who are going for transplant. So what are the factors to be seen for transplant is the liver size, presence of liver fibrosis, and inadequate iron chelation. So if all three are absent, the patient is class 1, locally class 1 we say. If one or two of these risk factors are present, class 2, and if all three adverse risk factors are present, class 3. So important three things to be seen: liver size, presence of liver biopsy, liver fibrosis, and inadequate iron chelation. So three things, and if nothing is there out of this, the patient is class 1, excellent outcomes of doing transplant in these individuals. Class 1 and class 2 patients are considered low risk with excellent long-term outcomes. Class 3 is considered high risk because they have a higher incidence of rejection and transplant-related mortality. And novel conditioning regimens like busulfan and cyclophosphamide we have seen, they have given results in the tune of 50%. So we have to have some new drugs which can be used for class 3 patients where the transplant outcomes can be improved. So if you see this historic data, if patient is class 1, the chances of thalassemia free survival is around 90%. But if suppose patient is class 3, locally class 3, then it goes to 58%. So it's very important the transplant is done early, before the liver fibrosis has established, before the inadequate chelation has established. So all these things are very important, and if you do transplant early, the outcomes are more than 90% success rates. So now take class 3 as a case scenario. Class 3 is very heterogeneous. Now these two patients we have taken for study. One has liver size of 3 cm, other has liver size of 7 cm clinically. Both are inadequately chelated and both have fibrosis. So now if you see further, one is 3-year-old, other is 14-year-old. One has splenomegaly, one has no splenomegaly. So these two factors are not considered. The age is not considered in the Lucrelli classification. So by chance, anybody can tell the patient who appears to be more high risk compared to a patient 1. But if you classify them as only Lucrelli class 3, that will not give justice to the high risk nature of the patient number 2. You understand what I mean? So patient number 2 is more high risk than a Lucrelli class 3. That's what I want to say. So it's a heterogeneous group where you can't just classify them as class 3 for all patients. So what at CMC level first time what they have done is indigenous classification of class 3. And what they have considered is two factors. One is age. If suppose in class 3 patient, age of the patient is more than equals to 7 years and liver size is more than equals to 5 centimeters, they have classified it as class 3 high risk. And the outcomes are very poor in them. So if you see class 3 low risk and class 3 high risk. So when liver size is more than 5, more than 2 centimeter classifies to the class 3. But if it is more than 5 centimeter, it classifies to the class 3 high risk with age more than 7 years. They have considered the age factor also. And they found that there is definite difference in outcome in patients with low risk class 3 compared to high risk class 3. So again, this paper from the blood which shows that age less than 7 years without hepatomegaly has excellent outcome compared to a patient who has age more than 7 years with hepatomegaly. This is multi-centers data that has been published in CIBM. That is a society where all the data is pooled together. And that again shows that age, if it is less than 6 years, 90% success rate, compared to a patient who underwent transplant at 16 to 25 years has around 60% success rate. So it's very important you do a transplant, offer transplant early in the age. So evaluating and how to help patients with class 3, because what we see in our practice is majority of the patients who go for transplant are class 3. Hardly any patient is class 1 or class 2. Hepatomegaly is already there, liver fibrosis is already there, and inadequate chelation is already there when they come for transplant. So almost practically more than 95% of patients who get transplant in our country are class 3. So something we have to do for them to optimize their results as well. So evaluation of different dose schedules, what we can do, like we can change the conditioning regimen, we can play for the graft rejection and immune reconstitution, we can increase the stem cell dose and see, we can reduce the intensity of conditioning so that the VOD and other complication will not happen, and we can reduce the toxicity of myeloablative conditioning by using a new drug called as triosulfan. Instead of busulfan, to use triosulfan, and we see what happens with this. So this conditioning regimen has made a lot of change by conventional conditioning versus new drug triosulfan based conditioning. And if you see the outcome, this is the historical cohort of busi conditioning compared to triosulfan conditioning, and there is definitely a significant difference in outcome when the newer conditioning regimens are used even in high risk patients. And high risk transplants are also approaching to a patient who are low risk patients. So outcomes are almost equal with the change in the conditioning regimen that is used for transplant in high risk individuals. Okay, so what change has done is the busi is the classical conditioning. We have changed it to triosulfan based conditioning, and the outcomes of class 3 patients are now equal to class 1 and class 2 patients. So coming to haploidentical stem cell transplant, we know like 2-3 patients from Sangli also has underwent a haploidentical stem cell transplant at some centers in country. So we should know that half match transplants are also done for thalassemia. So there is a new technique in half match transplants that is called as graft engineering for T cell depleted transplants. So in 1995 it has started. So initially what they used to do is they just used to take out the stem cells, CD34 positive stem cells. CD34 is the marker of stem cell, and rest they have to remove. But what they found is the immune reconstitution is very delayed and the patient gets a lot of infection if you do that. Then what they have done, they have removed only the T cells and B cells, and NK cells and other cells they have kept. Then after that what they found, in T cells there are two subsets of T cells. One is TCR alpha beta cells and TCR gamma delta cells. TCR alpha beta cells are culprit for GVHD and other problems. But gamma delta cells are important for immune reconstitution and immunity in the patient. So what they have done, a subset of T cells, TCR alpha beta is removed, but gamma delta is kept in the graft. So this is just to give an idea what is TCR. These terms you may hear somewhere, like somebody talking about haplotransplant. We have done a TCR alpha beta depleted transplant. That means T cell gamma delta cells are kept inside the graft, only alpha beta are depleted. So what they have done, haploidentical donor means we know parents are donor, siblings can be a donor, or kids can be a donor for an adult individual. So anybody can be donor. With this magnetic beads, what they have done, they have removed the T cell, alpha beta T cells, and the rest of the hematopoietic cell milieu is all kept same. So once alpha beta is removed, this is for a haploidentical transplant. The complications of GVHD and rejection are reduced, and the outcomes are improved with the even with the half match transplant. So this is a simple timeline that is being shown. The conditioning regimen is done, donor is mobilized. On apheresis, this alpha beta and CD19 cells are depleted, and then the graft is infused. And important thing is, if you do this, the alpha beta cells are gone. The chances that the patient will develop GVHD is very less. So no post-transplant graft versus host disease prophylaxis in terms of immunosuppression is required. So after doing transplant, no treatment is required. So even without immunosuppressive therapy post-transplant, they can do well. So that is the idea behind this. So if you remove the cells which are culprits for graft versus host disease, then what will happen is the patient will not require any immunosuppression after doing the transplant. This is the first thalassemia child, Satyanarayan, 1991 in India, and this is Dr. Maman Chandy, the mentor who has done began the transplant in our country, and this is the child who underwent first transplant. So in summary, allogeneic stem cell transplant remains the only curative option as of now for doing for thalassemia patients. Pre-transplant clinical status impact on outcome. As we all know, younger age is better. Better transfusion, leukodepleted blood, using filters to reduce the CMV infections, chelation therapy should be appropriate. Better indigenous risk stratification, as we have seen how the high risk class 3 is divided into high risk and low risk, because of which the outcome has been changed and the outcome are improved with the use of newer conditioning regimens. Novel conditioning regimens such as triosulfan and thiotepa potentially improve the outcomes even in high risk cases, and equal improvements in mud transplant, match unrelated donor transplants. So the outcomes with match unrelated donor, I have not shown this because of the time constraints, but they are almost equal to a sibling transplant. So even if it is donor is from outside and full match, then also we can give equal results with the match unrelated donor transplant. And emerging data for haplo identical bone marrow transplant again seems to be very promising. So even because now the families are small, there are hardly 1 or 2 siblings, or there are no siblings. Even there are no kids now, no DINK family we call, double income, no kids. So but at least one child is there. So for that particular child, if there is no sibling, how to do transplant? So the parents can be a donor for that. So haploidentical stem cell transplant is again an emerging story in case of thalassemia transplants also. Thank you. If you have any questions, I'll be happy to take, or later on we can take whichever.
What is the earliest stage to advise transplant?
So usually, sir, we advise transplant to do it after 2 years of age. Ideally is to do it as young as possible. Only because of practical issues to handle the child, it becomes little better when the child is more than 2 years.
Because the period that we tell and they actually think is almost 2 years. That's why I asked. Because I have been behind 4 of my patients for the last 4 years. It took 3 years to go for HLA typing. And after HLA typing, still they are thinking.
So, but at least child should be 2 years. We don't take do transplant less than 2 years, because the center line managing the child, lot of things becomes problem. So about 2 years it becomes little easy to handle the child. But earlier is better. So if you can handle a child of 6 months for doing a transplant, you are absolutely fine. We can do that. Yes, sir.
Unrelated to this.
Yes, sir.
Of late, we are getting cases of vitamin C deficiency. Thalassemia. So it's a very tricky situation. We give vitamin C, you have to give, because the patient will really be in pain.
Yes.
You can give vitamin C, iron absorption in this.
So that is actually quite relative about the, because we are not giving any additional iron supplement. Whatever you are talking about iron absorption that has increased is from the dietary iron.
Yeah.
So that is, I think, in the pool of blood transfusion that is going on, and the amount of iron that is going on from the blood, I think that absorption causing iron problem is quite negligible. That's what I want to say.
Actually, this I have been following. The ferritin levels keep on increasing. When you give
Vitamin C.
Stop vitamin D, again it goes into
Scurvy. So, but
that's a tricky one. My last one, sir.
So the problem of absorption related iron problem happens in case of thalassemia intermedia, who has not, suppose a thalassemia intermedia person is not regularly transfused, but still they can be iron overloaded. And there is a recommendation to use iron chelation in thalassemia intermedia who are not requiring transfusions. So only thing that you can do in this situation is, even if the patient is not transfusion dependent, suppose, and the ferritin is going above 1000 to chelation.
Because along with that, the units have
But because you have to treat the scurvy,
that dietary absorption is going to increase 10 to 15 times.
Correct.
So even without blood transfusion, that iron is going to get increased, and that's why it's one of the criteria for transplant is that you adequate chelation
And in thalassemia intermedia, the pathophysiology is that the patient has ineffective erythropoiesis, and that itself is a driver for excessive iron absorption. Even the patient is iron overloaded.
Yeah.
So even all thalassemias are actually more absorbing iron, because the ineffective erythropoiesis is causing decrease in hepcidin levels and causing increasing iron absorption. So that only chelation can help, sir, in that situation. Scurvy needs to be treated.
The second question is, my oldest surviving patient is 32 years old.
Okay.
He has 2 children, married and 2 children.
Okay.
Now he wants a
Transplant.
to do it.
So it depends, sir. Like
He is not very much. Once in 2-3 months he requires
transfusion. So it's a thalassemia intermedia more, because 32 years of age and not requiring too much of transfusions. So it depends upon the whether he has full mass donor or not. If he goes for haploidentical transplant, I will say no. because age plus why to take so much of risk when it is going well up to 32 years. But if he has a full match donor, and if he has quality of life issues like gross hepatosplenomegaly, like appearance problems, but that may not even get reversed as well at 32 years of age. So hopefully, if everything is going on well with few transfusions, let it continue like that for 32 years.
So the one thing what you mentioned in that slide was that liver size and criteria 2 centimeter and 5 centimeter. So that is less. It is below right question mark.
Yeah, it is clinical. Sir.
That
it is
is
not
that's
liver.
It's
just
not the whole liver span.
No.
It is just a
It's
2
just
centimeter
clinical.
below right question
So you
mark.
have to palpate it
Yeah.
with a tape. You have to measure below the costal margin.
Because the
It's a clinical
PG should
criteria.
not take a wrong message that
It's not a
measured
liver
to-
span.
Yeah, it's not the total liver span. It is the number centimeter below
And it's
question
not
mark.
on ultrasound. It's a
Yeah,
clinical
it's a
measurement.
clinical measurement.
I think I thank Dr. Nemani for this excellent lecture, and it shows about 50% has gone into our brains, and we need repeated lectures like this. Thank you.
Thank you, sir. I request Srinivas sir to felicitate Nimani. I request Dr. Vag sir to felicitate Dr. Srinivas sir. Our next session is an online session, and our next speaker is Dr. Abhilasha S. Madam, who is a pediatric hematologist and oncologist at KLE Prabhakar Kore Hospital, Belgavi, and professor in Department of Medical Oncology at JNMC. She was a gold medalist in her MD and has done fellowship in pediatric hematology and oncology from Bharati Vidyapit, Pune. She has worked as a senior clinical and research fellow at Tata Memorial Hospital, Mumbai. Madam's areas of interest are hematological malignancies, hemolytic anemias, inherited bone marrow failure syndromes, and HLH. She has 42 publications in reputed journals and has contributed chapters on pediatric oncology in pediatric textbooks.
You can share your screen. You can start with the speaker.
Can you see my slide?
Yes.
Okay. So, shall I start?
Yes, ma'am.
So, at the outset, I would like to thank IAP Sangli District Branch, especially Dr. Harshal Bag, for taking all the efforts. And the topic given to me is gene therapy in thalassemia, which has recently become a reality, a sort of revolutionary therapy for thalassemia in the Western countries. It has not come to our country yet, but hopefully it comes to our country soon. So, as Dr. Nemani sir told about the current curative therapy in transfusion-dependent thalassemia, currently what we have in our country is allogenic hematopoietic stem cell transplantation, and it has certain limitations as mentioned earlier, like we really face challenge with the donor availability as a match sibling donor. There's 25% probability of getting a match sibling donor, and match unrelated donor ranges between 20 to 30%. There's a significant risk of transplant-related complications like graft versus host disease, graft rejection, organ toxicity, second malignancies, and even transplant-related mortalities. And last but not the least, obviously the financial toxicity in our country. So, taking into account all these complications, gene therapy seems to be an attractive clinical option. And it has certain advantages over transplant, like donor is not required. The procedure-related mortality rate has been reported to be very low in the clinical trial so far. There's absolutely no need for immune suppression, and there's no risk of acute or chronic GVHD or even immune-mediated graft rejection. So what exactly is gene therapy? I would try to simplify it, and in the next subsequent 10 minutes, I'll be telling about the basic concepts of gene therapy and its application in thalassemia, as it is going to be a revolutionary therapy for thalassemia. So as the name itself suggests, gene therapy is correcting the faulty gene by using the person's own stem cells or hematopoietic progenitor cells. And the aim is to change the abnormal gene by two methods, either by introduction of exogenous DNA sequences or therapeutic gene into the host genome. And this eventually results in modification of the specific mutation and the correction of unusual function. For example, in thalassemia, the unusual function is ineffective erythropoiesis. So we are targeting this ineffective erythropoiesis by correcting the mutations. There are other techniques also, which I'll be telling in the subsequent slides. So in short, if we see this picture, there's a patient with beta thalassemia. So the first step, as in bone marrow transplant, is in autologous transplant, that is the selection of the stem cells. So this patient is subjected to apheresis technique, and stem cells are collected. Once they have been mobilized, so the stem cells are collected, and these stem cells of the patients are sent to the processing center or the laboratory where the magic is done. So now these are the patient's hematopoietic stem cells. Now these stem cells, in order to correct the genetic defect in these stem cells are co-cultivated with a gene is added. Now this gene is carried by a vector, and this is transfused into the hematopoietic stem cells in order to correct the mutation. That is one technique. Or the other technique, that is gene editing, where we target a particular gene of interest and we modify it inside the patient's stem cells. Now these are genetically engineered stem cells which are subjected to quality control procedures, and once these stem cells have been modified, they are cryopreserved, and the patient is subjected to myeloablative conditioning, just like in transplant, what sir mentioned in his slides about we are ablating the patient's own stem cells in order to create space for these genetically engineered stem cells. And once these genetically engineered stem cells have been infused into the patient, and once they engraft successfully, then the patient starts synthesizing his own beta globin gene, or there is upregulation of fetal hemoglobin as in the other technique, and the patient becomes transfusion free. So this is the basic concept of gene therapy. Now there are various types of gene therapy in thalassemia. The commonest one, the oldest one, that is the gene addition, which was approved in 2022. In this technique, this is the simplest technique where there is addition of a new beta globin gene, then gene correction where there is repair of the beta globin gene point mutation, and the most recent technique which got Nobel Prize recently, that is the CRISPR-Cas9 technique of gene editing. In this, we aim to restore the fetal hemoglobin production and thus alleviate the symptoms of thalassemia. Here we are not correcting the mutation, but we are targeting some other gene so that the switch from the fetal to the adult hemoglobin does not happen, and there is upregulation of the gamma globin so that the transfusion requirement comes down. Now coming to the first technique, that is gene addition. So in this technique, a functional beta globin gene is inserted into the patient's own hematopoietic stem cells. So as I mentioned in the previous slide, so this is a patient who has got transfusion-dependent beta thalassemia. So now the stem cells are mobilized by giving colony-stimulating factors, and the stem cells are collected. Now these stem cells are sent to the processing center where they are purified, and these purified stem cells are subjected to a large batch of ultra-purified viral vector which contains the normal beta globin gene. And now these stem cells of the patients are co-cultivated with these vectors which contains the normal beta globin gene, so that this normal beta globin gene is transfused into these hematopoietic stem cells, which are then subjected to quality control procedures. So all this is happening outside the body of the patient. And then the patient undergoes myeloablation, and after that these stem cells are, these genetically modified, genetically engineered stem cells are introduced into the patient. So gene addition, as the name suggests, here we are adding a normal beta globin gene into the patient's stem cells and infusing in the patient. Now, just 2 words about the vector which is used for the transduction of the beta globin, normal beta globin gene into the hematopoietic stem cells of the patient. So, the vector used is the lentiviral vector, the retroviral vector, lentiviral vector, and the name is BB305 vector. So, as we can see here, this is a beta thalassemia erythroblast, the RBC of a patient who is suffering from beta thalassemia. So the patient has alpha tetramers, as there is no beta globin chain production. The patient has does not have a normal beta globin chain production, so alpha is pairing with alpha. So the patient has abundant alpha tetramers, which are causing the which is responsible for the hemolytic anemia, and the patient is transfusion dependent. Now, what we are doing with the help of this vector, this is a normal beta globin gene. And the vector contains this normal beta globin gene. The normal beta globin gene is added to the vector, and this vector is transfused into this beta thalassemia erythroblast. And once the engraftment has happened, there is synthesis of normal beta globin gene. So alpha pairs with beta, and now this ineffective erythropoiesis comes down, or it stops, and then the patient has normal erythropoiesis. I mean, the ineffective erythropoiesis halts here, and the patient becomes transfusion free. So these are the lentiviral vectors which are used for gene addition in thalassemia, that is BB305, and there are several modifications of it. Trials are going on. So as far as this gene addition technique of gene therapy is concerned, so trials are going on since 2006. And all the trials, I mean, the cumulative result of these trials were published in this remarkable paper in New England Journal of Medicine in the year 2022. And the results were really highly rewarding. 91% of the patients became transfusion independent. And the median duration of follow-up was almost 2.5 years. And they could maintain an average hemoglobin level of around 12. And they were completely transfusion free. So the results were very good. And after the results were published in this paper, the FDA approved this gene addition technique for gene therapy in thalassemia. Now the biggest barrier to this gene therapy, the success rate is really good, but the biggest barrier is the cost. So the current cost approximately is 2.8 millions, which translates to 22 CR in Indian currency. But very soon our Indian companies will get into it, and hopefully the cost would come down. So everything comes with its own risks and complications. So there are certain complications associated with transgene integration therapy. That is one of the biggest problems is insertional mutagenesis. What is insertional mutagenesis? When we are inserting the gene of our interest, there are chances that the surrounding genes can get activated, and especially if they are oncogenes. So there can be activation of the endogenous oncogenic genes, and there is always a risk for cancer. And because of this risk, many trials of gene therapy in sickle cell anemia were stopped, because they found that after the gene therapy, a few patients developed AML. So the trials were stopped, but there are not many reports of insertional mutagenesis in the trials for thalassemia. Another graft associated complications like the graft failure, there can be delayed engraftment, and due to the conditioning therapy, busulfan is the conditioning agent which is used in this, so there can be hepatic veno-occlusive disease and infertility. So these are the complications associated with gene addition technique in thalassemia. Now another very interesting technique, that is the gene editing technique, and we all must have some basic idea about this, because this was given Nobel Prize last year. So before I go to this technique, this is a bit complicated. So just few words about the pathophysiology of beta thalassemia. So as we all know, the fetal hemoglobin is alpha 2, gamma 2, and adult hemoglobin is alpha 2, beta 2. Now because in thalassemia we don't have beta globin chain, so alpha pairs with alpha, and there is excess of alpha chains, which are the main culprits for hemolysis. These alpha tetramers, because alpha pairs with alpha forming the alpha tetramers. So these alpha tetramers disturb the internal ionic balance of the RBCs, and this leads to hemolysis and ineffective erythropoiesis, and the patient becomes transfusion dependent. So if we create something for alpha gene to pair with, like gamma, if there is upregulation of gamma globin, so Dr. Preeti will be talking about the pharmacological therapies in thalassemia, and upregulation of the fetal hemoglobin by upregulation of gamma globin has been found to be the most promising therapeutic approach in thalassemia. So something similar is done in this gene editing technique of thalassemia. Here we are not correcting the defective gene in thalassemia, which is very difficult. As we know, in thalassemia, so far more than 250 mutations have been reported. So it is practically impossible to correct so many mutations to validate. It's practically very difficult. So this gene editing technique is very promising. Now, in this gene editing technique, that is a CRISPR-Cas9 technique, we are targeting a particular gene, that is BCL11A. Now, what is this BCL11A? So, this BCL11A is a gene, or it is a key regulator of normal switch from fetal to adult hemoglobin production. As we can see here, around 6 months of age, the switch over from the fetal hemoglobin to the adult hemoglobin is completed, and the gene responsible for it would be isolated. It will be sent to the processing center or the laboratory where this gene editing happens. So in this, in the genome of this patient, in the stem cells of this patient, we will target this particular chromosome number 2, which have this BCL11A gene, which is responsible for the switch from fetal to adult hemoglobin. And as we can see here, this particular gene is edited. This is removed. So once this is removed by this CRISPR technique, there is no switch over from the fetal to the adult hemoglobin, and hence there is upregulation of the fetal globin. So this is the modified stem cell, which is cryopreserved, and the patient undergoes myoablative conditioning. And after that, these genetically engineered or genetically edited stem cells are infused into the patient, and once they engraft, the patient does not require transfusion. So it's a very interesting technique. Now, how this downregulation of the BCL11 is done? The process of gene editing with CRISPR-Cas9 technique. So what we are doing is we are targeting the chromosome number 2, the genome in the chromosome number 2 with gene BCL11 gene, and we are creating multiple insertions or deletions within the non-folding region of this BCL11 erythroid lineage specific enhancer on chromosome 2, so that the other lineages, that is the myeloid lineage or megakaryocyte lineage, is not affected. We are just targeting the erythroid lineage of this particular gene, and then it is the downregulation of the BCLA in the erythroid precursors is done, or silencing of this gene. The silencing of the gene, which is responsible for switch over from fetal to adult hemoglobin, and there is no effect on the other hematopoietic lineages. So the results of the various clinical trials on this CRISPR-Cas9 gene editing therapy for thalassemia was published in NEJM recently in 2024, and after this study was published, this was approved. So what they found, the results revealed that transfusion independence was obtained in more than 91% of the patients, and so the results were very promising. And after this, it got its FDA approval just few months ago, and this was awarded Nobel Prize. So to conclude, the treatment with Beticel or gene addition resulted in a sustained adult hemoglobin level and a total hemoglobin level that was high enough to enable transfusion independence in most of the patients. Similarly, gene editing technique was also very promising, and it showed transfusion independence in exactly 91% of the patients. Gene therapy has got, although it is currently a very costly option, but there are various benefits of gene therapy over transplant. That is, there is no risk of GVHD, so the mortality rate, treatment-related mortality rate is very low as compared to transplant. There is absolutely no need of immunosuppression, and above all, the biggest advantage, no donor is required in gene therapy. Thank you. Be happy to take questions.
Do we have any questions? Okay.
Our next speaker is Dr. Preeti Naik Madam, who is a pediatric hematologist and oncologist and working presently as an assistant professor at Dr. D.Y. Patil Hospital, Medical College and Research Institute. Her areas of interest are thalassemias and other hemolytic anemias. Madam has worked on various projects like anthropometric assessment in transfusion-dependent thalassemia patients and comparison of endocrine complications in transfusion-dependent versus non-transfusion-dependent thalassemia. Madam has published a paper in Unexplained Bleeding, the Manifestation of Glanzmann's Thrombocythemia.
Screen share and then make her the you need to unmute yourself. Yes, in screen share.
Screen share is not sharing. Only the host can share in this meeting.
Dr. Abhilasha, you need to.
Yeah. Hi. I mean that option of change host is not there in this.
Just next to her screen. There is
Okay, next to her screen. Okay.
Yeah.
Make host. Yes.
Yeah.
Yes. I did that. Okay. Done.
You can share your screen.
Yes. Yes. Is it visible, sir?
It got disconnected.
Sir, is it visible?
It was visible, it got disconnected.
Yes.
You can meet the host and share the make me the
I think Sangli district, right?
yes.
It's done?
No. This screen. Host.
You are host, sir.
Yes.
Yes, you can start your talk.
So, good evening, everyone. First of all, I want to thank you, IAP Sangli branch, and especially Dr. Kalima for giving me this opportunity. So, today I will be talking on the novel therapy in thalassemia. But before going to this novel therapy, let me have a look quickly. We will have a quickly view on iron chelating agent. So, we know we have 3 types of iron chelating agent like dexterioxamine, deferricerox, and deferriprone. So deferriprone, that is a chelker which we are aware. Dexterioxamine means Decirox or Deferrigate or Asumra tablet. And dexterioxamine, that is the injectable of subcutaneous. So next slide please. Dexterioxamine is given as an intravenously or subcutaneously, and its half-life is very low, that is 20 to 30 minutes. So better to give a continuous infusion using a specific pump, that is a Thalassemia pump. That is specific for this dexterioxamine. It is just similar to your syringe pump, but some difference is there. And the dose for dexterioxamine is 20 to 40 mg per kg per day. See, subcutaneously, this patient, if you are advising subcutaneous dexterioxamine, then patient can take it at rest during night period, so that during daytime they can do their activity, they can go to school, or they can go to college, or do their job. So subcutaneous subcutaneous infusion is very good for giving dexterioxamine. The results are very good. The dose is 20 to 40 mg per kg per day, and it is useful for severe iron overload in liver as well as in cardiac. Yes, the complications are there like skin reaction or hypersensitivity reaction. Then we can't give this in a young age children because of a bony issue, and some fundal changes will be seen. So fundoscopy evaluation, after evaluation, we have to do this annually. If someone is using dexterioxamine, like sensory neural hearing loss is very common with this. So that's why monitoring is very important in the form of audiometry or a fundoscopy in this patient. Also, this dexterioxamine can cause the liver and hepatic as well as the renal toxicity. So the monitoring in the form of LFT and RFT every 6 monthly we have to do. Now coming to deferriprone, which we were using. So this Kelper, it is an oral drug and the half-life is very short, that is 2 to 3 hours. So we have to give it in a TDS dose or a QID dose. It can be given with the food dose is 75 to 100 mg per kg per day, depending on your serum ferritin level. If anyone is not economically good for T2 MRI, you can change the dose of the deferriprone as well as all three chelating agents. And it has been found that deferriprone is very good chelating agent for a cardiac iron overload. The complication which is commonly seen is arthralgia or arthritis, which is the most common complication where patient will discontinue this drug. And the most severe is granulocytosis. So around 1% patient has granulocytosis. That's why on every visit you have to do CBC as well as the LFT, RFT in these patients. Decirox, sir, please previous slide. Decirox, that is a hello? Sir, please previous slide. Decirox is other second oral iron chelating agent which we are using nowadays very frequently. Dose is around 20 to 40 mg per kg per day. It has to be given on empty stomach, specifically early in the morning. And the complication will be in the form of liver function abnormality or kidney toxicity, as well as the kidney toxicity. So that's why kidney function test evaluation or a monitoring testing should be done every 3 monthly if you are using deferriprone. So initially we are using single monotherapy, but now depending on your serum ferritin level, if it is more than 2000 for more than 6 months, or if T2 MRI is suggesting of severe iron overload as well as in a liver as well as in a cardiac, then you can go for a combination. So in combination, you can use the oral chelating agent both, deferriprone or deferriprone, or you can use oral iron chelating agent as well as the subcutaneous dexterioxamine. The result is very good when we use a combination therapy in order to reduce this iron overload. Next slide, please. Now coming to novel drugs, we know already Dr. Abhilash as well as Dr. Nemani sir told you about the pathophysiology of thalassemia. So that there is a basic problem in a beta globin chain. So there is an absent production or a reduced production of a beta globin chain which causes a globin chain imbalance. So there will be excess of a alpha globin chain. And in that gene therapy plays a very important role. Dr. Abhilash already told you about this. Excess of alpha globin chain. So with this, that seems the destruction of RBCs also. So the process of erythropoiesis, so early stage will be there, but it is not erythropoiesis. So to avoid this, we can use this type of a drug or a ruxolitinib or a beta pain. So this luspatercept among these three drugs, ruxolitinib as well as the beta pivot, these are the pyruvate kinase inhibitor as well as the JAK2 inhibitor, and they are under phase 3 trial. So we are not using this drug. But recently, luspatercept is the first drug which was FDA approved. The previous slide. Previous slide. Which we are using in a TDT, that is a transfusion dependent thalassemia. This belongs to this is the recombinant fusion protein which binds to transforming growth Sangli lesion, and thereby it ameliorates the inhibitory effects of late stage disease. So basically, this drug is used for a erythroid maturation. Is used as a erythroid maturation agent, and we can avoid inhibitory erythropoiesis and the lifespan of RBC somewhat increase. So the blood transfusion requirement in these patients that will be increased. Next slide. There are various previous slide. So there are various studies which going on. First trial was done in 2020. That is a Believe trial, in which they have tested around 336 patients of more than 18 years of age group, and around 200 patients were in a luspatercept group, and remaining patients were in a they received a placebo therapy. So this luspatercept, it is given by subcutaneous injection. So at the end of 13 to 24 weeks, there has been found that around 21.4% patients, they have a reduction in a transfusion burden over a week of 13 to 20%. So that was very significant. Next slide, please. So luspatercept can be given in a children more than 18 years of age group. So especially adult patients who are transfusion dependent thalassemia, we prescribe luspatercept. Dose is very low, that is the starting dose is 1 mg per kg, which is to be given once in every 3 weeks, and subcutaneous injection it has to be given. Depending on the response, in next 3 to 4 weeks, you can increase the dose of luspatercept to 1.25 mg per kg. Before giving this medication, you have to do a liver function test as well as a CBC every time. It has been found that the patient, around 4% of patients were having thromboembolism in Believe trial, and that was because of a splenectomy, which was the high risk factor present, and that may be the cause for thromboembolism. Also, patients were having hypertension as well as fetal toxicity was there. So this drug is not advised for a pregnant woman as well as a lactating woman. What about the cost? The cost of this luspatercept is very high. So it is available in 25 milligram as well as 75 milligram. So 25 milligram, the cost is around 30 to 40,000. And for 75 milligram, the cost is around 80,000 to 1 lakh. So which is very high. So that's why in India also, any patient who is affordable, they can ask for a luspatercept or they can go for a luspatercept, but because of a cost issue, very less people are using this drug. So second drug is the second group. Second group is the so just 2 minutes I will cover it. Second group is the thalidomide group, which is the HPF inhibitor. So that will decrease the anemia and so that will eliminate anemia. To reduce the anemia, the blood transfusion requirement will be decreased. So thalidomide is a group where HPF production is increased by promoting the excretion of globin chain. Already Dr. Abhiraj told you that excess of alpha globin chain will bind gamma globin chain will cause the HPF, so the anemia will be decreased. So there are various trials, studies done in India also, like in Delhi, where the efficacy and the safety of the thalidomide was checked, and it has been found to be very effective, but it has to be done under monitoring because the side effects like peripheral neuropathy or constipation in some others are very commonly seen in these patients. So instead of doing some centers are doing instead of giving standard PhD per kg, they have given a 1 mg per kg and also effective very good impact. But there is no long-term safety data on a thalidomide use. So I think if in the future, if thalidomide can become can go to be a bone marrow treatment with ongoing trials to determine the right tolerable dosage in DDT as well as NDT. And there are other drugs like iron stimulation and so there these medications are under phase 3 trials, so not in use. So I think it is important to know that both TDT and NDT might see a big change in the management in the near future. Considering the gene therapy and immunosuppressants are already in the phase, and India is looking forward to this. Thalidomide, as it is a cost-effective, it can become a substitute for expensive drugs and treatment if more research goes on its safety profile. Thank you.
I request Dr. Shabana Madam to talk on the upcoming activities of IAP Sangli District Branch.
A very good evening to one and all present here. Without wasting much time, just to highlight a few events in near future, we have a World Environment Day on coming 5th of June. So I request every one of you to plant a sibling in your near house premises or hospital premises and take a snapshot of that and post in the IAP Sangli district group so that we can have a combined collage and report it to the Maha IAP. The second event which is upcoming on 6th of June is Complimentary Feeding Day. We are planning to have a awareness program and some poster competition at Government Medical College, Meerut. The plan will be discussed with you in the group. And in near next month, there is a IAP Charity Day in August. So we are planning to have donation of some sanitary pad vending machines and library books to the deserving students in the government schools. Thank you so much. I also thank Dr. Abhilasha and Dr. Preeti Naik for having a wonderful session and to add to our knowledge. Thank you both of them, ma'am. Thank you.
I request Dr. Mateen sir to extend the vote of thanks. We'll have felicitation of Dr. Kumbar sir by Dr. Vittal Mali sir in view of the Thalassemia event that was held on 8th May. Felicitation of Dr. Harshal sir on behalf of Dr. Gadkari madam by Dr. Amnapure sir.
Like Harshal. You okay?
Yeah.
Felicitation of Dr. Amit Tangare sir for delivering a talk on the protocols in neonatal jaundice by Dr. Shankar Kauda sir. Request Dr. Jeevan Mani sir to felicitate our MR Anil Kochade and sponsors. And we also have a short cake cutting ceremony by Anil Kochade for the launching of his products.